In today's episode, we cover the topic of abnormal uterine bleeding, or AUB, found under the gynecology section. Begin with a clinical snapshot. A 39-year-old woman presents with abnormal heavy menstrual bleeding, along with increased pelvic pressure. She denies pain and is not using any hormonal contraception. She uses multiple sanitary pads per day. On pelvic exam, there is an enlarged uterus with asymmetric contours. As a general summary, remember that this is also known as dysfunctional uterine bleeding, or DUB, and it refers to abnormal menstrual bleeding with regards to quantity, duration, or schedule. Also remember that the patient must not be pregnant. Therefore, pregnancy must be ruled out. In terms of its etiology, causes can include structural abnormalities, such as from adenomyosis, uterine fibroids, malignancy, and polyps. Other causes may include bleeding disorders and coagulopathies, medications, anovulation, and genital infections. Causes can be remembered with the mnemonic PALM COEIN. This refers to polyps, adenomyosis, leiomyomas, malignancy and hyperplasia, coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, such as from medications, and not yet classified, such as from arteriovenous malformations and chronic endometritis. In terms of the pathogenesis, the mechanism of abnormal uterine bleeding from anovulation is due to the fact that the corpus luteum does not form. Then there is an absence of progesterone, and the unopposed estrogen continues to proliferate the endometrium. Then the endometrium becomes unstable and outgrows its blood supply. Eventually, the endometrial sloughing and breakthrough bleeding results. Moving on to the presentation. Symptoms may include variation of normal menstrual cycles, symptoms of anemia, such as lightheadedness and shortness of breath, and physical exam findings will be dependent on the etiology. They may include obesity, hirsutism, and acanthosis nigricans, which can suggest polycystic ovarian syndrome, or there may be an enlarged pelvic mass, which may suggest a leiomyoma. In terms of other imaging studies, a transvaginal ultrasound is first line in adult patients when assessing for structural abnormalities. In terms of other studies, the evaluation will be dependent on the likely cause of the abnormal uterine bleeding. This may include beta-HCG in order to rule out pregnancy and can be a serum or a urine test. Blood testing may include a complete blood count. Coagulation studies should be considered in patients with a history of bleeding disorders. Thyroid stimulating hormone should be checked in those with a history concerning for thyroid disease. An endometrial biopsy can be considered in patients that are greater than 45 years of age, patients that are refractory to treatment, or patients less than 45 years of age with a high risk of endometrial cancer. In terms of the differential, make sure to refer to the mnemonic PALM COEIN discussed previously. With regards to treatment, remember that this should be aimed at the underlying cause of abnormal uterine bleeding. In cases of heavy menstrual bleeding, which are most commonly due to leiomyomas or adenomyosis, one may consider hormone therapy, such as estrogen-progestin contraception or levonorgestrel-releasing intrauterine devices, which are first line. Progestin-only treatment is also reasonable. One may also consider NSAIDs or tranexamic acid, which can be used in patients who do not want to be treated with hormone therapy or have contraindications. The NSAIDs decrease endometrial prostaglandin synthesis, which results in decreased blood loss. The tranexamic acid prevents plasminogen from being converted to plasmin. Surgical treatment options should be used in cases that are refractory to medical therapy or if it is the patient's preference. Remember that heavy menstrual bleeding due to leiomyomas or adenomyomas is an indication for surgery. However, one must assess whether the patient wants to become pregnant or has completed childbearing. Specific options include myomectomy, which can be an option in patients who desire future pregnancy. Other options include endometrial ablation